And would acknowledge the presence of Professor Mohammed Kuj, President of the Kerala Association of Neurologists. Please come to the stage, sir. And Dr. Pradeep Kumar. Vijay, come, please. Vijay is known to us. He is a pillar of Kerala Association. He is the current National Secretary of the Indian Stroke Association and past President of IMA KSP. So may I ask Mohammed sir to conclude the discussion.
It is time for discussion. Any questions or suggestions?
Sir, I would like to ask. There were some studies on series of markers like metalloproteases or elevated patient CADP. Like, so is there any proven thing, or can we go ahead with that?
No, I think that we would love to have better biomarkers. We'd love to have better biomarkers for CID, but CIDP is a syndrome, and it encompasses probably multiple different immunologically distinct disorders. And it would be lovely if we really had good markers, whether they serum or CSF. None has reliably come forward yet. We've certainly identified some specific antibodies, like NF155 and contactin, but I think that's where a lot of the work is going on. People like Luis Quirol in Barcelona is doing some very nice work, and the Japanese are doing some very nice work in this area. But we haven't really got enough evidence to say this is a reliable marker, whether it be it blood or CSF.
Second question is regarding the use of advanced MR imaging in these patients.
Yeah, thank you. I skipped over it pretty quickly here because I don't have a lot of good slides, and I figure it would be, I put it to one side, but I think it's really going to be very, very important. With new MR imaging techniques, we can get the most beautiful pictures of the nerves all the way up to and including nerve roots. You can see the plexus, and I think that's going to tell us some very important things. So for example, in multifocal motor neuropathy, I do have an MRI in the slide set which shows the enlargement of the nerves coming right up through the plexus to sorry, not multifocal motor neuropathy, in Lewis-Sumner syndrome, the focal form of CIDP, comes right up to the spinal nerves and then stops. And the nerve roots are normal, but the spinal nerves and the trunks and cords of the plexus are greatly enlarged. But I think it gives us access to segments of nerve that we can't study easily electrophysiologically. And so we are doing it more and more, and I think it's something that you ought to be setting up. I think we all ought to be setting it up at our centers. Any other questions? I'm happy to.
So how long we should treat this multifocal?
Yeah. So how long should we treat any of these conditions? I mean, autoimmune conditions tend to go into remission, but multifocal motor neuropathy, well, I think it probably does go into remission, actually. I think eventually it burns out and stops progressing. But how do you tell that is the case? You're giving the patient IVIG every 3 weeks. How do you tell when to stop? Well, what we do is steadily reduce the dose. And the problem is there's something about IVIG that makes people feel good. Is it just the placebo effect of having to go and get something done intravenously? I don't know, but it's something about it makes patients feel good. So when you're tapering the dose, you've got to have an objective measure. So we do quantitative motor testing. We use an expanded MRC scale, but we absolutely meticulously test strength every time. And as we are withdrawing the medication, we will not change that course unless the patient objectively deteriorates. And eventually you get to a stage where they don't seem to be responding to the treatment anymore. Are they going to continue to deteriorate? I think the evidence is yes, they are, but at such a slow rate that it's not related to immune attack on the nerve. It's just end stage, sort of like secondary progressive MS that doesn't respond to treatment, that maybe this is secondary progressive CIDP or secondary progressive multifocal motor neuropathy. We don't really know. So I think you have a responsibility to try to withdraw therapy in all of your patients that you're treating with immune-mediated disorders, because otherwise you go on with risky, sometimes very, very expensive treatment forever, and that's not justified. So constantly try to withdraw treatment, have an objective measure that you can follow. It would be great if we had a biomarker that changed along with the activity of the disease. The problem is we know a lot of biomarkers. Patients can go into clinical remission but still have the biomarker. The classic one being myasthenia gravis. Patients can be in complete remission in myasthenia gravis but still have antibodies. Think about that for a second. How do you explain that? It's true. But that would be ideal if we had a biomarker that enabled us to say, the disease is in remission, we don't need to keep treating. At the moment we don't have that, so you constantly try to reduce the dose and withdraw therapy. And that's true for CIDP as well as for multifocal motor neuropathy.
That's short one about the sciatic nerve stimulation, the sciatic nerves.
Yep.
Is it reliable and reproducible all the time?
Well, it's a very easy technique. It's something that I have done many times, and you just get one of the old monopolar. You don't stimulate with a concentric needle. It's a monopolar needle. You just put the indifferent electrode over the glutei, and then you put the electrical stimulus at about half a hertz, maybe 10 milliamps, and 0.05 milliseconds duration, and you just advance the needle down until you get a twitch. Now, if you get a twitch at 10 milliamps and 0.05 milliseconds duration, you're going to be able to, we know that if you can increase the current output more than 150% of threshold, you are always supramaximal. So it's a very simple technique.
Stimulating at the just below the biopharmacy.
Right there. And it's an easy technique, yep.
Just like CADP is dominant in diabetes, what about GBS? Is there any prediction for GBS in diabetes?
Again, those studies have not been done as well, but I think the answer is no. I think that diabetes does not increase your risk of getting GBS any more than it increases your risk of getting CIDP.
Recurrence of this.
So CIDP, about 80% of cases. It's hard to say these days because we tend to treat patients, but if you go back to the early days and look at the cases that were not treated because we didn't know what the treatment was, about 80% ran a progressive course and about 20% ran a relapsing course. So patients would seem to spontaneously, or some would seem to spontaneously remit only to relapse again later. But patients with CIDP do, unlike multifocal motor neuropathy, do go into remission, but it's remission. I always tell patients, you have CIDP for the rest of your life. And I've seen patients in remission for 5, 6, 7 years who then relapse when I thought they were done. So I think that you do need to be aware that many years after having CIDP, you think you've got rid of it, and they can reappear later.
CIDP also you can get varying degrees of involvement in different nerves. So how do we differentiate such things from multifocal motor neuropathy?
It's not always easy, is the answer, because CIDP is a very predominantly motor disorder. The sensory involvement is quite mild, but usually sensory nerve conduction studies are abnormal. That's the first point. Secondly, although there's a patchiness to CIDP, it's nearly always bilateral. If you go back to the 1975 paper from Peter Dick, he emphasized the symmetry. And I know what he was doing. I mean, I've talked to him about this, and I know he wasn't saying it's absolutely, strictly symmetrical like an inherited demyelinating neuropathy, but he emphasized the fact that this was a predominantly symmetrical disorder. And the patchiness is much more in the nerve conduction studies than it is clinically. I also think that CIDP has both proximal and distal involvement. I think the tough ones are the Lewis-Sumner patients. And I think, talking about academic jealousy, years later I'm still irritated because the Lewis-Sumner patients, one of those patients was my patient, and they didn't put me on the paper. I was very annoyed about that. But the Lewis-Sumner patients are these strikingly multifocal patients who are now thought to be focal forms of CIDP. But they do have sensory involvement. It's still predominantly motor, but they do have sensory involvement. In fact, if you look at all the Lewis-Sumner patients, they all had low amplitude or absent sensory potentials. So I think it can be difficult, and it's important because if you give, I didn't mention this in the talk, but if you give steroids to patients with MMN, what happens? They get worse. They get often dramatically worse, which is telling us something, but I don't know what it is. So I think you just have to be a little cautious about that. But meticulous search for sensory involvement, electrophysiological or clinical, that the global nature of the reflex loss, these are, so even the Lewis-Sumner patients tended to have a very widespread reflex loss out of proportion to other effects. So it's usually pretty straightforward, but can occasionally present challenges, particularly early on in the course of the disease.
These diabetic liposacral radicoplasm, do you use immunotherapy and so on?
We could be here for the rest of the night. So this is a subject that is very dear to my heart because we described some of these original patients in which we biopsied the nerve and showed that they have vasculitis. So that diabetic lumbosacral radiculoplexus neuropathy, as Peter Dick has called it, or diabetic amyotrophy, diabetic mononeuropathy multiplex. This whole range of conditions are due to a diabetic vasculitis. It's a monophasic illness and tends to have an active phase of about 6 months, then a plateau, and then a steady improvement, sometimes with complete recovery, but quite a lot of people are left with disability. So I think that's justification for treatment. And so we actually reported an observational series of study of patients who had responded dramatically to steroids. The problem was it wasn't a controlled study. And people seem to have fallen into two camps. The Indian camp seems to be, this works so well, it's unethical to do a study using placebo to prove it. The American camp seems to be, there's no double-blind placebo-controlled study proving it's beneficial, and it's therefore unethical to treat patients with this because they're diabetic and you're giving them steroids. And try as I might, I can't get a controlled clinical trial done. We tried to do it at St. John's, and nobody wants to give placebo. So I always give them steroids, pulse steroids, for 3 months. If you give less than 3 months, they relapse. We've never had a relapse out beyond 3 months. And so we treat them for 3 months. And it's one of the most miraculous things. You've got these patients with 10 out of 10 pain, absolutely miserable, significant weakness. You give them steroids, and within 24 to 72 hours, their pain is 90% better. They stop taking opioids, they stop taking gabapentin, they stop taking everything. And then they get better. So yes, I treat them with corticosteroids, 500 milligrams of methylprednisolone by mouth once a week for 12 weeks. Actually, we've treated a few with IVIG, and the pain gets worse. And we think that's because it increases serum viscosity and reduces nerve blood flow through inflamed, narrowed, small blood vessels to the nerves. So we don't give IVIG to these patients.
Can you give clinical clues to differentiate bilateral plexopathy from the CADP for students?
So bilateral lumbosacral radicular plexus neuropathy does occur. It's nearly always asymmetrical, so that it definitely can be bilateral, but usually striking asymmetry. Second is there's nearly always pain. So I can't say I've ever seen a patient who has no pain. Pain is not always severe. It usually is severe. So asymmetry, presence of pain, and temporal evolution is the third. The diabetic amyotrophy patients evolve quickly, often almost overnight, and usually are in your office, or at least in the orthopedic surgeon's office. In my experience, they often don't get to see neurology as the first step within a few days, because this is really awful pain. And then the final point is, as I've said repeatedly, the diffuse areflexia in patients with CIDP. Even areas you didn't think were involved usually have lost reflexes. So there is a series of clinical clues that distinguish between them. I should mention that there is a very rare form of bilateral symmetrical proximal weakness in diabetics that we don't really know what it's due to. But I've maybe seen 2 cases in 50 years, so it's not very common.
Gigi.
In situations in GBS, where we give immunoglobulins first, the patient doesn't improve after 2 weeks or so. So what is your approach now? You go on to a space of plasmapheresis or repeat immunoglobulins? If so, how long to wait? Suppose if I want to start plasmapheresis, how long should I wait now?
Right. So do we practice evidence-based medicine, or do we just follow our instincts? And I think in this situation, I practice evidence-based medicine. There is no evidence that a second treatment in patients with GBS is effective. None at all. And it's a hard thing to do. You've got a patient who's got GBS, who's in the ICU, perhaps on a ventilator, and they haven't responded to your first line of therapy. It doesn't matter whether it's IVIG or plasma exchange. I tend to use plasma exchange, but it doesn't matter. You give one, and then there's the temptation to give the other. I've seen lots of patients who didn't improve during the treatment, and then after the treatment had finished, about a week later, they start to improve. And if I had given them the second treatment after the first one had finished, I would have attributed that to the second treatment. I think we have to follow evidence. The evidence is that there is no benefit of instituting a second treatment.
So that was a fantastic evening, and I'm happy that Dr. Parry has given us a wonderful update on CADP in diabetes, as well as we are happy that we are hearing from the person who has described multifocal neuropathy. So that's, I must thank Dr. Gigi for asking us for doing this, and Kent has taken it up, and Dr. Reggie has materialized it. So it's a very, very good event for Kerala Association of Neurologists, because we have just started our this year's program, and I hope that we'll be able to do more things in the coming years. And similarly, because we are just trying to think about certain activities like investigations of GBS and related disorders. There is we all know that there is a slight increase or reporting of Zika viruses and the relationship of Zika with GBS. So as we are thinking for getting a registry on GBS and trying to do virological studies for Zika to know whether such a relationship is there or not in Kerala. So
Could I just say one thing? That there is an international study looking at just that. It has centers in Sri Lanka, Bangalore, Pakistan, Myanmar, Vietnam, Laos, Thailand, and Singapore. And we are studying the relationship.
Bangalore also?
Yes.
It's your course to collaborate
So we in fact, the protocols with the ethics committee as we speak, we hope to get an answer next week. And so we're ready to start recruiting patients. So yeah, we're looking at Zika, chikungunya, dengue, Japanese encephalitis, West Nile. Is there any, I think those are the big five. so yeah, with that's ongoing.
On behalf of Kerala Association of Urologists, I request Dr. Mohammed sir to give a memento to our guest, Dr. Parry.
Thank you, all of you, for coming over here and attending this meeting. And special thanks to the sponsors, Sun Pharmaceutical Industries. And thank you all. And the meeting is adjourned for further fellowship and dinner. Thank you.